welcome to Health Alert. I'm Pam Butler. Today we're going to talk about some common and not so common conditions. And joining me is Dr. Malcolm Buford. He's a nephrologist at the University of Oklahoma School of Community Medicine in the Division of Nephrology. Welcome to the show, Doctor.
Thank you.
Now, you've been here before and we've talked about different things related to kidney health and things such as that. This first uncommon condition is not really related to the kidney per se. And it's called, I'm going to get it right, Kartagener's.
Right, yeah, Kartagener syndrome.
Kartagener syndrome. Now tell us, what is Kartagener syndrome?
So Kartagener's, and actually I had a patient in Washington where I was prior to coming back to Oklahoma who had it. And his mother had actually heard Dr. Kartagener speak. So he always corrected me. So I'm not quite sure if it's Kartagener's or Kartagener's.
Okay.
According to this patient and his mother, the physician said his name was Kartagener.
Okay.
But it's actually on the spectrum of a set of diseases called primary ciliary dyskinesias, or where you have small little hair-like structures in your body diffusely, usually sinuses, lungs, the spermatozoa that are made by the testes for men, the thing that help to fertilize eggs, also have cilia in them, and essentially they're hair-like projections that help maintain motility. So in primary ciliary dysplasias, or PCDs, for the time being, they don't beat right. They don't move correctly. They don't propel the sperm, so to speak, or in the case of the lungs and the sinuses, they don't mobilize mucus appropriately. So in Kartagener's or Kartagener syndrome, it's actually a triad. It's the primary ciliary problem, mixed with chronic sinus problems, bronchiectasis, which is chronic dilation and mucus buildup in the lungs, combined with something called situs inversus. And that's actually probably the most fascinating part of this syndrome. Cilia are responsible for normal organ distribution in the body. Okay, so
now, what do you mean organ distribution?
Right. So as you develop in utero in the body, you have this form called the neural crest. And the cilia help to mobilize where your liver is going to go, where your heart's going to go, and the like as you develop as an embryo. Otherwise, you'd just be a block of cells. So because they don't mobilize or they don't move correctly, you'll sometimes, in about 50% of cases, see the heart on the wrong side of the chest. And the bowels arranged kind of in a reverse order. And we call the heart that's fixated on the right side dextrocardia, as opposed, meaning right-sided heart, as opposed to it being on the left. And that turn of organ placement is called situs inversus. So the triad of that, the situs inversus, the sinus problems and persistent infections, and then the lung manifestation of this disease, the bronchiectasis, which is, I can talk about that, but that triad is called Kartagener's.
Now let me ask this, and we'll get back into more details. How are you born with this? Is this a genetic malfunction? Does it have something to do if the mom doesn't drink enough juice or take prenatal vitamins, or exactly what is it?
It's actually an autosomal recessive disease, and it has nothing to do whatsoever with prenatal care or how well someone does. In addition, there's what's called a heterozygous state where, as opposed to the gene problem being 100% apparent, it usually has what's called variable penetrance, meaning that it'll show up a little bit in certain situations, right? So a baby, for instance, would constantly have upper respiratory infections, or always have sinus problems, or not develop sinuses in the front of their head. And not that you'd see that, but you'd notice that the child was constantly congested or gagging or something like that. And then as they age through life, they'd have recurrent, apparently asthma, but in actuality they'll develop, like I said, this bronchiectasis, this chronic smoldering infection in the lung.
Well, let me ask a couple more questions. Does this affect males more than females? And then is this detected, like you're saying, as they develop throughout life, you'll see these complications? Well, you said the heart was on the right side instead of the left side. Wouldn't that be part of the pediatric or newborn exam? Those two things.
It is, actually, and that's probably how it's mostly found, is, it's going to be found more in early in life. Now the long-term lung manifestations may be missed. And like I said, only 50% of the people have the right-sided heart.
Okay.
In addition, dextrocardia, which is just that flipping reverse, in the Scandinavian populations, its incidence is about 1 in 10,000, but only about 25% of those have Kartageners. So it's really not a true or related one-on-one relationship. You can have some of the manifestation without the full-blown, triad of that disease.
Okay, now
And then
males.
so far as men, actually, there's not a higher predilection. It's one-on-one. It's just that it shows up in men because we have motile sperm. So in them, they may have immotile sperm that are still able to fertilize. So if you had what's called intracytoplasmic sperm injection, where you actually take the DNA of the sperm and inject it into the cytoplasm of the ovum or the egg, then people can become fertile. But sometimes they'll have sperm that actually do move slightly, but they can't move sufficiently to penetrate the ovum or the egg and fertilize it. So oftentimes it's male-sided infertility. That's sometimes the only clue that they have the problem.
Now, in terms of you're talking about they may have more sinus infections, more lung issues, infertility. Are those the kinds of things that sort of shorten the lifespan, or do people with Kartageners tend to live as long as the normal expected lifespan, especially if your heart's on the right side instead of the left?
That's an interesting question. I would actually suspect, and I don't know for certain if they have a decreased lifespan. My gut feeling is that they do, just because patients with bronchiectasis and patients with chronic sinus infections who are continually needing antibiotics, and actually the maintenance of patients with PCD is to treat them aggressively and early on with antibiotics, even if you develop resistant organisms, because when you do develop bronchiectasis, your lifespan is greatly shortened. Okay. And so in that fashion, I think it's a secondary decrease in or increase in mortality. Because they do develop these end organ damaging effects of the disease. Okay,
now with this, because we know the downside of antibiotics in terms of, like, say, being resistant in that, so you're saying that they're put on this sort of prophylactically throughout their lives, or just as they happen to get infections?
Probably just as they happen to get infections. I think that the treatment is aggressive when they manifest signs of active infection. I'm sure that there are some physicians that would put people on a low dose of a chronic, let's say, tetracycline, for instance, but ideally they treat infections, particularly once they know the organism and its sensitivities. They'd have guided therapy to minimize exposure and minimize the development of multi-drug resistant organisms.
Okay, now another question. For those who are fertile, you said some can reproduce, some individuals with Kartageners can reproduce.
Right.
Is there a great likelihood that their offspring are going to be affected, like 50%, or is it 25%, or is it 100%?
It depends on who has the gene, and it depends on, like I said, it's variable penetrance. I think that it's something that you have to counsel families about and actually tell them, if one of the parents or both of the parents have it, it's a high likelihood that their child is going to have the disease. Ultimately, I think you just have to see what happens with the child. Okay. And it's more a matter of educating the parents and letting them know that they need to take special precaution or have their ears up for signs of the child having issues.
Okay. One last question before we go to break here. If the child is affected, especially in terms of looking at sports and activities, do things have to be restricted for them, or can they pretty much participate in the full gamut of what kids do?
I don't suspect that this actually interferes with someone's ability to perform to whatever degree they are afflicted by recurrent infection. Long term, I mean, there's even been bilateral lung transplant done for patients who have this issue. And I think the first one was in Spain in a 15-year-old girl who had double lung transplant, which is fairly aggressive. Okay. I mean, and there are a lot of diseases that mimic PCD. For instance, cystic fibrosis, which is a completely separate anomaly that causes abnormal, like thick, viscous mucus to happen because of a chloride channel problem. But they'll have a similar presentation. And in that same situation, they'll get lung transplant in order to live longer. So I think it's a matter of treating the end organ more so than, trying to impair them from being able to explore life. I think it's more maintenance.
Okay. And when we come back, we're going to tell our viewers we're going to talk about another rare condition, uncommon, called von Hippel-Lindau.
Very good.
All right. Please stay with us. We'll be right back.
When it's time for lunch, a sandwich is a quick and easy choice. And with the right ingredients, it can be good and good for you. So I'm here today to see who can build the ultimate sandwich. All right, when the time is up, our judges will give you their scores. Ready, set, go! Okay, Jason starts out with a multi-grain roll. Ooh, Allison's stuffing her pita with, yes, spinach, a great source of iron. Jason isn't skipping on the protein, adding plenty of smoked turkey, just like Allison's putting the finishing touches with crispy red bell peppers for a dose of vitamin A. Time! It looks like we have a tie. We'll need to call in our special guest referee.
Now these are what I call quick, delicious lunches. Whole grain breads, a whole variety of ingredients. There are so many different ways to build delicious, healthy sandwiches. These two get high marks in every category. I'd say you're both winners. America.
Let's get healthy together.
Welcome back to continue our discussion talking about common and not so common conditions. Joining me again is Dr. Malcolm Buford. He's a nephrologist with the University of Oklahoma School of Community Medicine in the Division of Nephrology. Let's jump in, Doctor. Now, as I promised, von Hippel-Lindau. Did I say it right?
Von Hippel-Lindau.
Von Hippel-Lindau.
VHL.
VHL. What is that?
VHL is a genetic abnormality that results in the development of capillary-based or blood vessel-based masses and tumors in the body. Has an incidence of about 1 in 36,000, 1 in 50,000 people. But so far as from a nephrologist perspective, it's on our differential when we see someone who has cystic disease of the kidney, as well as like a very high hemoglobin count.
Okay, now explain to people what hemoglobin is who may not know.
Okay, so hemoglobin is a protein that's made and stored in red blood cells from your bone marrow that helps to carry oxygen and deliver it to tissue in your body. So when we talk about someone being anemic, we talk about them having a low hemoglobin.
Okay.
So.
Now, with this von Hippel, VHL, you're talking about tumors. Are they in all the different organisms, or is it just concentrated in the kidney, or can it tell us where they are?
They're in multiple different organs. So the vast majority of these are found in the spine, or what we call infratentorial. So there's a tissue plane in the brain, in the spinal canal, if you will. And most of these vascular tumors that are called hemangioblastomas are found in the spine, about 50% of them. Some of them are found in the cerebellum, which is the base of the skull of the brain that actually helps with balance and involuntarily learned movements. And very rarely are they found, about 2% above inside the brain. Then they're found in the eyes, sometimes found in the lung, at times found in the gut, rarely. And then at times they're found in the testes or in the epididymi, which are the tubes that kind of connect the testis to the urethra, if you will.
Okay.
And they're found in the Brog ligaments also in women.
Now, with this, tell us what are some symptoms that people have, because it sounds like it's sort of pervasive in just various areas all over the body. So what would a person show? I mean, what symptoms would they have? So
for those that are in the spine, and they can start pretty early, less than 20 years of age. So for the ones that are in the spine, people can have sporadic, isolated neurologic deficit. So they may have sudden weakness in an arm or whatnot, or sometimes facial weakness depending on where it is. If it's in the skull, if it's in the cerebellar area, they may have what's called ataxia, or a disturbed ability to walk or coordinate their movements.
Okay.
If they're in the eye, which is actually somewhat of the more severe issue, and those are the ones that need to be monitored frequently, they can have retinal detachment. So the retina, which is a coating on the back of the eye that houses the rods and cones, so to speak, the way that you see color in black and white images, that can detach because of a bleed. And they can also be in the optic nerve. So those are much more difficult to manage and necessitate the treatment by an ophthalmologist, an eye surgeon.
Okay. Now, you talked about some of these if they appear before the age of 20, these symptoms. Is this something that you would notice upon birth in some kind of way in terms of movement, or is it where you have to grow a bit for these to then impact those particular organs?
I'm not sure how it really presents in children. I've only seen one case of VHL in clinic, in practice, and even then that was during my fellowship some years back. So, but the presentation I don't think is really limited based on age. I think it's going to happen depending on where the tumors are. So obviously as we age, we have a higher likelihood of having these things develop. As a matter of fact, so far as kidney dysfunction is concerned, or the presentation of these hemangioblastomas in the kidney, VHL is actually much more associated with the development of cancer in the kidney. And so when we see, like I said, a kidney cancer and someone having a very elevated hemoglobin, that kind of is a cue to look in other places for these issues. The first one obviously being the eyes, because of the need to make sure that they don't have detachment, and then doing imaging studies in the spine. So if someone comes in and they've never previously assumed that they had involvement somewhere else, they just kind of thought that, well, every once in a while I'll have this symptom, or I'll lose vision in an eye. Those are pretty good signs that we need to look in those areas.
Okay. Now with this too, because you mentioned about the eyes and that's very hard to treat, yearly eye exams become very important, because is this something that the doctor, optometrist, or the ophthalmologist, whoever you're going to, can pick up on?
Yeah, usually they're going to be referred, these patients, right? So they're going to be told, we're concerned on, having a yearly eye exam ought to happen anyway as a regular health check, right, early on in life, both looking at visual acuity, the need for glasses and the like, but they'll follow them sometimes much more frequently than every year. They'll follow them every couple of months, because if they see a lesion, you have to determine whether or not you're going to intervene. Sometimes these things are very slow growing and they really are fairly innocuous, and other times they're pretty abrupt, and you may need to do what's called photocoagulative surgery, which is where they use a laser and actually kind of coagulate or shut down the blood flow to the vessel mass, or they may have to go in, surgically and remove these things to spare the retina. Okay,
now with these particular tumors then in different parts of the body, treatment, you're talking about the treatment for the eye, can they be surgically removed? Can they be treated with some type of radioactive substance? What are the treatments?
Yeah, so in the spine, they're often just observed until they produce symptoms, because you don't obviously want to enter many times into the spinal canal, both because of scarring and because of the risk of infection. So they'll have guided radiotherapy, so they'll sometimes have external beam radiation from like a radiation oncologist. They may use x-rays to destroy the integrity of these tumors and collapse them and sclerose them. Cryoablation has been used, which is where they'll take a cold probe and they'll make a small incision and insert the cold probe on top of the fluid, the mass, freeze it so that it no longer grows and the cells die off. So yeah, there's some less invasive therapy, and then if it comes to it, then yeah, they can do surgical exploration and remove them.
Okay, now once these are removed, are they constantly growing? Do they? Okay, it's not where once it's gone, it's gone. They will come back.
Yeah, and they may not come back in the same place. It may be a completely new lesion. But the reality is that the person has the genetic makeup to make these hemangioblastomas, and so they have to constantly be under surveillance.
Okay, now with this, in terms of sort of lifespan, do individuals with this condition tend to have a normal lifespan? And also tell me about reproduction. If they reproduce, is there a 50%, 100% chance that they will pass this genetic component?
Well, there are some spontaneous mutations with VHL, and then there is a genetic predisposition to it. So there is a pretty significant 50% chance of passing it on to a child. So far as it shouldn't impair their ability to reproduce.
Okay.
There is a well demarcated list on or stratification scheme on who is at risk for the development of different aspects of VHL. So again, it's not just the blood vessel tumors that form these hemangioblastomas. It's also families are broken down into whether or not they have a high or low risk of developing a secondary tumor called a pheochromocytoma, whether or not they have a higher risk of renal cell carcinoma, which is the kidney cancer that we talk about.
Okay.
Most of which are all clear cell. I mean, I think 99% of renal cancers associated with VHL are the clear cell variant, which can be treated and excised. So yeah, it's a lifelong thing, and it does shorten lifespan. It's about 70% incidence of kidney cancer at the age of 60 for people with VHL. Okay. So it isn't necessarily infrequent that they have the development of these tumors. Okay. But again, thankfully, the incidence is extremely rare. 1 in 36,000.
Exactly. And really quickly before break, male versus female affected are pretty much
same.
Even?
Yeah, pretty even.
Okay. We'll take a quick break and come back and talk about a few more common things.
Okay.
Okay. Please stay with us. We'll be right back.
The forest is a magical place for your whole family, with animals and fun all around. Ooh. So discover the forest and explore all the wonder that's there. Visit discovertheforest.org to find a forest near you.
Welcome back. To complete our discussion, talking about common and not so common conditions, joining me again is Dr. Malcolm Buford. He's a nephrologist with the University of Oklahoma School of Community Medicine in the Division of Nephrology. Let's jump in, Doctor. Okay. Now, I want to focus this segment on some real common area, like kidney stones. Tell us, what are kidney stones?
Kidney stones are concretions or stone, a conglomeration of crystals, if you will, really, elements in the urine that, cause pain and discomfort and are often formed secondary to either dietary noncompliance or different disease states. Okay,
now when we think about that, when you say dietary noncompliance, so I want to get this one out there. I have to while I have time. Does that mean like you don't take in enough cranberry juice? I mean, people have often heard if you have cranberry supplement or cranberry juice, you can diminish or eliminate kidney stone possibilities. Is that truth, fiction, or what?
It's a partial truth, which are always dangerous things. So cranberry juice, most juices contain a certain amount of citric acid, and in turn, or citrate really, and in turn they can bind up some of the calcium that leaves and gets into your urine. Stones come in many different varieties. So you have uric acid stones, you have calcium phosphate stones, calcium oxalate stones, and then some other less soluble items like acyclovir, for instance, a medicine commonly used to treat herpes, or AZT, a medicine commonly used to treat early on in HIV therapy. Some of these things will crystallize out into the urine and can precipitate stones. But in particular, the calcium, which usually follows salt into the urine, will pair up with oxalic acid or oxalate, and that can be minimized with the use of citrates. So lemon juice is actually probably a little bit better thing to take if you're trying to stay away from stones because it's higher in citric acid.
Okay, so lemon juice?
Lemon juice, like the little lemon. Not that this is not a trademark ploy, but the lemon that you can get, the real lemon stuff, that's good enough.
So would you just take like a teaspoon of it or a table?
Teaspoon in a glass of water every day will help to minimize that. It'll help to replete some of your citric acid stores. Okay, now with this, especially the ones that are calcium-based, that has implications for people probably thinking milk or things that are high in calcium. I mean, should we be limiting? I mean, we talk about calcium supplements that we need. How does this relate to that calcium requirement? Yeah, that's difficult because it depends on what sort of stone former you are, one. It depends on what your diet consists of and what you eat with your calcium source. So if you are just having a glass of milk on an empty stomach, you're probably going to absorb more of the calcium than if you were to have that with breakfast, for instance, you know, if you're having a grapefruit or something like that alongside of it. So, you know, there's actually some recommendation not to limit your calcium intake if you have stones, because In doing so, you'll actually kind of reabsorb more of the oxalic acid in your diet. One of the things that people will often do that I don't think that they really think about is take excessive amounts of vitamin C, like around cold or cough season, flu season.
True.
And vitamin C converts over into oxalic acid, which then has to come out into your urine. So you'll actually have a higher likelihood of developing stones during that period if you're not well hydrated, if you're taking excessive amounts of vitamin C. So it's not always healthy to overdose on certain things.
Okay.
You know, to take well above the recommended daily allowance actually can be harmful to you.
Okay, so really that concept of eating a well-balanced meal is what really kind of helps guard against maybe the development of kidney stones. But you said something that was interesting, that if you're likely to develop, are we more prone based on our genetic makeup or our cultural background or racial or anything like that, male versus female, to be prone to developing kidney stones?
Yeah, we are. Actually, there's several diseases that will increase your likelihood of developing stones. And also behavioral things, so laxative abuse, or Crohn's disease, or things, you know, like chronic recurring diarrhea will increase your incidence of stone formation because of the amount of oxalic acid that you'll absorb. People who have lupus or Sjogren's syndrome, or patients who have multiple myeloma, they're also at higher risks of developing stones. Occupational hazards actually can predispose you to developing stones. So people who are hatters, for instance, who work around a lot of mercury, or people who have who weld, who use cadmium metals, or are exposed to a lot of lead, will actually have a higher incidence of stones, because these things cause what's called a proximal tubular acidosis. They'll actually cause a change to the kidney ability to function and maintain appropriate balance in electrolytes that it absorbs and secretes, and so that'll actually predispose them to stone formation.
Okay, so it's more of an environmental or sort of dietary work related, not so much in terms of our background, male versus female or anything like that.
Well, men are more, so when it comes to uric acid stones, there is a predilection more for men, because men typically have more uric acid. We eat a lot more protein. We tend to drink more beer. We don't tend to diet as well as women do.
Okay.
And so we have a higher likelihood of having uric acid, just like we have a higher incidence of gout, for instance. You can kind of think of uric acid stones in the urine as a precursor, or as a consequence also, the same process that causes gout.
Okay. Okay, well, I'm going to have you back. I am always almost out of time. But there are more questions I have on that, of course, but I'm going to have you back to sort of maybe pick that one up and talk about some other conditions that you mentioned. Okay. So thank you for joining me.
You're welcome.
Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear your questions, comments, or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Or if you're on the email trail, please email me at healthalertusa@gmail.com. And also visit me on YouTube at youtube.com/healthalertusa. And remember, talk with your doctor, get the right sort of drugs that you need if you have a problem, get the right nutrition to prevent the drug possibility, and just take care of yourself. Be well.